Oregon Health Authority with the HIV, STD, TB section. I'm the new medical director there. I've been there for about 3 months now. So I'm going to talk to you about the CHIME-IN study and the data we collected. Just fairly recently we closed this study, so it's hot off the press. So the National HIV Behavioral Surveillance System is a CDC-funded project. It started in 2001, and we started in Portland about 3 years ago to join 22 other participating cities with 3 annually rotating target populations, which I'll show you. And the real purpose is to monitor trends in behaviors and use of prevention and care services. It's an anonymous survey. That's computer administered with a face-to-face interview and an HIV test. So the 3 annually rotating populations are high-risk heterosexuals, which we did in 2016, men who have sex with men in 2017, and then we just finished our people who inject drugs portion of the study in 2018. And so eligibility is you had to live in the sampling area, you had to be at least 18 years of age, and have injected drugs in the past 12 months. And we also did respondent-driven sampling for this study. So we recruited 509 people in the Portland metro area, and it's really Multnomah County and Clark counties are the ones that are most represented. So one of our sampling areas is Clark County, Washington, so the Vancouver area. So 60% were male. We had 27% people of color, 30% were less than 30 years of age, 80% identified as heterosexual, 57% were homeless, again 95% from Multnomah or Clark County areas, and 90% reported ever being incarcerated. It was about 50% for the past year, and almost 50% reported some form of drug treatment in the last year. So I want to start off with this first statement of people who inject drugs put harm reduction into action. And I know people in the community know this, but I wanted to just point out that we're capturing this such that over 80% had ever carried naloxone. About 60% currently have naloxone in their possession, and a little over 60% used naloxone in the past year. And their sources of naloxone were overwhelmingly a community organization or a friend. And then almost 75% witnessed an overdose in the last year, and in response to those overdoses, 60% used naloxone to reverse, okay? In addition to a bunch of other things that they did, but the life-saving intervention was the naloxone. And so you're gonna have a little deja vu, with the percentages are a little different. So we did Hep C rapid testing as part of the study as well. And so 28% were negative, 25% or so, a quarter, were newly positive, so didn't know they were HCV positive, and then we did a rapid test and they came back positive. And then there were 47%, so almost 50% who said, yes, I have Hep C, and then the rapid testing just confirmed what they knew. And of those, that 47% who had known that they were HCV positive, about 10% had ever had a direct-acting antiviral for hepatitis C treatment. Okay, so these are messy, but a little complicated slides, a lot of numbers, but I'm going to put little boxes around the things that I'm pointing out, so just to direct your attention. So we saw that Hep C negative folks injected less frequently than the folks who self-reported that they were positive or were newly diagnosed with Hep C. We also saw that the folks who were Hep C negative tended to use more meth than those who were self-reported positive or new HCV positive. But those who were new HCV positive tended to use the meth and heroin together simultaneously. In terms of timing and location of prior Hep C testing, so of course, as you would expect, the folks who know that they're Hep C positive, they got tested in the last year, so almost 60%, with lower proportions of the Hep C negative folks and the new Hep C positive folks having been tested in the prior year. And most people got tested at a doctor's office or clinic, but then the hospital was also a frequent location of testing for those who already knew their hepatitis C status. And also correctional facilities for those who knew that they were Hep C positive or were newly positive. And I just want to point out that kind of low in the drug and alcohol treatment facilities. So that's why I'm pointing that one out, which I think we could do a better job of. And so how about equipment sharing and injection partners? So the self-reported positives and the new Hep C positives were more likely to have used a needle after someone else in the last 12 months or have used works from someone else in the last 12 months. And the new positives and the self-reported positives were a bit more likely to have passed on a needle to someone else after using it. And most people who are Hep C positive and knew it knew the Hep C status of their last injecting partner. And most also in that category also said that they had a Hep C positive injecting partner who was their last injecting partner, whereas the percentages for those two variables were lower among the Hep C negatives and the new HCV positives. And then to healthcare. So most folks were currently insured, and those who were Hep C negative or self-reported positive had a healthcare visit in the last 12 months. And it doesn't necessarily mean a primary care visit, it's just some interaction with the healthcare system. And then for folks who are newly Hep C positive, I thought this was a pretty big difference, having a usual source of care. So those who reported being Hep C negative or self-reported positive, over 80% said that they had a usual source of care as opposed to the folks who were newly Hep C positive. So there's an opportunity there. And most folks had ever been tested for HIV. Again, a little less among those who were newly Hep C positive. And almost, I skipped over this, but having received sterile needles in the last 12 months, almost the entire population had done that in the last 12 months. And so where did people get them? So overwhelmingly needle or syringe exchanges, okay? But then the other large percentage of locations, or well, not locations, but other people, were someone who then got them from a needle exchange, so a secondary exchange in a way, maybe not formalized. And then finally, for folks who tested Hep C negative, over 50% were accessing sterile needles at a pharmacy or a drugstore. And while we didn't ask about severe infections, we did ask about skin soft tissue infections, and we might expect those to be more common than the osteomyelitis or endocarditis. And we did notice that the Hep C negative folks were less likely to have experienced those infections, although quite high percentage-wise, than the self-reported positives and the newly Hep C positive folks. Okay, that's my last number slide. So from that first slide, sort of thinking about how we can continue, and I think a lot of this stuff work has been being done in the community, which is wonderful to hear, is how can we empower people who inject drugs? So increasing access to naloxone. Most participants assisted someone who overdosed in some way, most using naloxone for reversal. I know we may need to think about expansion of Good Samaritan laws to protect people who reverse overdoses. And then one of the things we were really seeing is that folks are getting their naloxone from peers and also getting syringes from peers. So can we expand or assist with supporting peer-to-peer naloxone distribution, peer-to-peer syringe and works distribution exchange, some sort of hub and spoke model for some of the fixed exchanges that are currently present, and then extending their reach. And then like Todd, I'm going to talk a bit about some institutional changes to support drug user health, definitely expansion of Hep C screening, and really think about this panel-based testing, right? When we think about Hep C, we think about HIV, we think about hepatitis A and B, and we think about STI. And I feel like we have opportunities, especially for drug treatment programs, and actually also correctional facilities, to implement these types of wraparound testing services. And also, I mean, we're public health people, so vaccinations and making sure we're seeing Hep A outbreaks, particularly among homeless folks, and so that may cross over with other populations. So really kind of thinking also immunization and base level primary prevention. And then again, continuing to expand syringe services. Are there needs for population-specific syringes or syringe exchanges, serving particular populations, potentially based on race or ethnicity, that might encourage more folks to access syringe exchanges? And then you heard a lot about the work being done in rural areas and really expanding syringe exchange and access in rural areas. And then the Multnomah County model of starting to integrate medical and behavioral health into syringe exchange, or having syringe exchange be the the gateway into healthcare, I think, is really important because you're offering services that people definitely need, and you're like having a little step ladder, so it's graded for people where they need to, where they're ready to access services. They're there, which is sometimes the issue, like, you know, needing behavioral health services, but then not being able to get them. Okay. And then again, expanding access to curative therapies, the recent ruling, which was phenomenal, and then are we going to start formalizing these micro-elimination efforts, things that the tribal folks have been doing really beautifully in Oregon. So how can we do that as well with other populations? And then healthcare provider education and support to do drug user health, which goes to the conversation about training OHSU folks, training PAs in University of New Mexico. So there's a lot of opportunity there. And there's also this issue of, like, when people come in with skin and soft tissue infections, are folks realizing that, oh, this may be indicative of injection drug use, and is there an opportunity for discussion and screening there? And then really recruiting and nurturing providers who want to serve people who inject. So we are always happy to present our data. We also have a lot more information than I presented. So if there are particular questions or things you want to see, let us know. Amisha and Lauren are wonderful, and Amisha, they both helped me put this presentation together, and they keep this project running. So we are always happy to share data and collaborate. So please let us know. Thank you.